Thank you for being here on this wonderful, rather brisk Colorado morning. I'm Don Elliman. I have the privilege of being the chancellor of this campus, if I haven't met you. And we're here to talk on the first of our lecture series for 2019 on the subject of transforming healthcare with artificial intelligence. Um, we, uh, we have three of these lectures every year, or three of these events every year. There'll be one later in the spring and one in the fall, and we're delighted to host this one today. We do this really to spread the word, to talk about things that are going on in healthcare that we think are important, that are going to make a difference, and sort of give you a sense of what the role of this campus is in that mission. In the past year, we've covered topics like the opioid crisis, the latest research in cancer, our effort around CU innovations, and harnessing the immune system to fight a variety of diseases. As I said before, we'll have two more of these in the spring and the fall. Today, we're going to be talking about the potential role and use of artificial intelligence in healthcare. It's a term we've all heard. It's widely expected to transform the relationship between people and technology. This will surely bring many positives, but also raises some concerns. We'll hear this morning from three professionals whose expertise and perspectives approach the topic from very, very different angles. The first, or one of our speakers is Dr. Clay Smith. He's a professor and associate chief of hematology at the CU School of Medicine. He is the director of our Blood Disorders and Cell Therapy Center at the University of Colorado Hospital. His research has advanced the science on blood cancers such as leukemia and lymphomas through identifying and manipulating malignant stem cells. In recent years, developments in bioinformatics have dramatically expanded the ability to analyze these cells. Dr. Smith is at the forefront of this work, helping to develop a novel strategy for targeting leukemic stem cells that has very promising implications for wider use. And he's leading a joint effort for us with a partner that we hope will be really transformative. We also have Dr. Foster Goss, Assistant Professor of Emergency Medicine at CU Medicine. He specializes in clinical informatics, the application of informatics and infotechnology on the delivery of healthcare. His research is on how, in the ever-growing amount of information in electronic health records, relevant clinical information, which frequently gets buried, can be more easily and effectively assessed by providers to make time-critical medical decisions for patients, especially applicable in emergency department settings. His recent work uses data to provide more intelligent support on clinical decisions involving allergies and adverse reactions. Last but certainly not least is Dr. Larry Hunter, who will be our first speaker. Larry is the professor and director of computational bioscience program at the CU School of Medicine. He is an internationally known scholar, one of the founders of the field of bioinformatics. He was recently named one of the top 100 AI leaders in drug discovery and advanced healthcare by Deep Knowledge Analytics, a magazine I was not familiar with until today. In an article in Forbes last week, these rankings said their work is quite likely to enhance the quality of life, surpassing the most vivid science fiction imagination. He's also known for his work on ethical issues related to AI and medicine. So without further ado, I'm going to invite Larry Hunter to the stage. Larry.
Thanks, Don. So I want to start off with a bit of a cautionary note. This is Matt Velosa's high technical officer at Microsoft. They had this wonderful line. I got my degree in artificial intelligence in the 1980s, so I've been through several of these boom and bust cycles. And while there is tremendous promise and a lot of important new technology coming down the pike, I want us all to take a deep breath and not worry too much about the robot overlords quite yet. All right, so what this is, Python is a programming language, so if your machine learning thing is written in Python, if it's written in Python, it's probably machine learning. And this kind of presentation, written in PowerPoint, is the AI stuff. Okay, so take a deep breath. It's all going to be all right. Give you the machine learning in one slide. The way this technology works is we start off with a lot of examples. Tons and tons of training data, examples of images, examples of text, examples of measurements, and then we have some outcome we're trying to predict. We'd like to know what category this element is. Is this a picture of a dog or a picture of a cat? Is this a picture of a cancer cell or a normal cell? And we take those thousands and thousands of training examples and run it through an algorithm, and we come up with a predictive model. We're trying to predict something. And then we can take some new document, some new image, some new measurements, and apply this predictive model to it, and we'll get a predicted label. What class is this? Is this a dog? Is this a cancer cell? That's really the essence of what this machine learning technology does. And this is called supervised learning. There are a few other things I'll mention in a minute or two. But this is the sort of main tool. And this has been a tremendously powerful tool. Okay, this is how Alexa works, or Siri, when it's trying to understand what you have to say. It has lots and lots of examples of people saying things that it's going to know how to do. You know, buy me soap. And with enough examples of that, this machine learning algorithm can figure out how to recognize different ways of saying, get me some soap. All right, and so we want to understand that it's powerful that it generalizes that well. And it's really important that we can do this without knowing any particular rules. No programmer said, okay, if you're going to recognize a dog, it's got 4 legs and a tail and a long snout. Nobody had to write that down. It all came from the learning algorithm looking at lots and lots and lots of examples. All right, and that's a powerful thing. It's much easier in some respects to write computer programs to learn how to make a distinction than it is to write down in fine detail how to make that distinction. But that's all it's doing. All right, this is not magic. There's nothing too scary about this. It is not going to replace people or doctors or anything like that anytime soon. But it's a very powerful tool. And so we can use this tool for doing diagnosis. And what I'm going to show you now, this is an important one because this is an actual clinical trial, so a prospective one, tested the same way we test drugs or new medical devices to meet the standards of the FDA to prove that we're not doing snake oil. And what this is a machine learning system that does something called detection of diabetic retinopathy. And what that means is these are pictures of your retina. This is a healthy retina over here. This one has some bad little signs in it that you're starting to get some problems with your retina that's secondary to having diabetes. And this is important to detect because there are a lot of people with diabetes, and a fair number of them will develop this kind of retinopathy. And if you catch it early, you can treat it and either slow down the progression or prevent the progression of the disease and prevent blindness. This is probably one of the most actionable things we can do to prevent unnecessary blindness is detect this early. But one of the problems I just mentioned is that there are 30 million diabetics in the United States alone. There are nearly 500 million diabetics around the planet. If every ophthalmologist spent all day screening people for retinopathy, we still wouldn't be able to keep up with the load. We wouldn't be able to refer everybody to the treatment that they need. And not a terribly high percentage of diabetics actually have retinopathy. So it's not like everybody needs it. We just need to be able to tell these little bad dudes from this healthy one. And if we can get a machine to do that, if we can train a computer program with thousands of these images to figure out the differences between them and do it in a pretty reliable way, that would be a big deal because we could do a lot more screening. We could prevent a lot more blindness. And this is a good example of how one of these machine learning things might turn out to be useful in medicine. And this one's even more interesting for the global implications. Although we can't do it quite as reliably yet because of the quality of cell phone cameras, you can more or less put this in a cell phone. And that way people could screen themselves. And if we go around the world and we look at places that are medically underserved, there are a lot more cell phones than there are doctors. And so if we could pick up diabetic retinopathy in the early stages for people using only their cell phones, and maybe somebody who has this software installed on their phone and knows how to make the referral, but at a much lower level than an ophthalmologist, maybe we could prevent a lot of blindness in the world. And this, I think, is the way of looking at the promise of artificial intelligence in medicine in a less hyperbolic way. There are important things we can do like this that really would make a difference if only we could get them right. And so this is, I think, the exciting potential of machine learning in medicine. There are interesting things that happen when you train up these algorithms. They see things that people sometimes don't. One of the interesting consequences of that diabetic retinopathy work is it turns out men and women have different retinas. We didn't really know that, and nobody cared to test because it's kind of easy to tell men versus women without looking at retinal fundographs. But nevertheless, It turns out that this AUC thing is called area under the curve. It's kind of a technical measure of how accurate it is. This is kind of, you can think of this as 97% accurate. We can figure out gender by a retinal photograph. Well, that's kind of a surprising result, not terribly practical, but sort of interesting. This one's a little more practical. So high potassium levels in the blood, you know, a doctor could pick it out on an EKG, but your smart watch can also figure this out. And that's a lot easier than hooking you up to an EKG. And so that's sort of a surprise. And then maybe we could actually give doctors vision using these machine learning tools and things they couldn't see so well before. So these are polyps, something I care about as a something male. I really worry about this sort of thing. And it turns out that some of these things are a little hard to see. Maybe if you're good, you could see them. But the machine learning systems can pick them out really easily during colonoscopy. And it's a way to use these machine learning systems to give doctors a better insight, better vision, the ability to pick things out that they might not have been able to pick out without these tools. And so this is a way that machine learning systems and doctors can work together to do a better job of what that doc is already doing. And that's really the goal here, is not to replace doctors, but to augment them, to help them do a better job, to spend less time doing boring stuff and more time doing the things that really matter to help patients. We do have to be a little bit careful. These machine learning systems will pick up on whatever is in the data. And just because we can predict something doesn't mean we can do anything about it. And this is a really interesting example of that. So these are blood draws. The blue ones are normal results when you have blood work done. The red ones are, let's see, I don't remember what we're measuring. I think the red ones were too high and the brown ones were too low. And what these are measurements at different times of the day of your blood work. And what this shows you is if you're having blood drawn at 4 in the morning, 4 or 5 in the morning, your chance of dying in the next 3 years is extremely high. All right? It's very predictive. And even if you have a normal blood draw and it was drawn at 3 or 4 in the morning, you're much worse off than somebody who had an abnormal blood draw that showed up at noon. Okay? And so this is really scary looking, but it does not mean that we should stop drawing blood from people at 4 in the morning because it's not going to help them live any longer. Okay? It's a prediction, but it doesn't give you control over it. It doesn't say that if we change this input, we stop drawing blood at 4 in the morning, that would help you in any way. So we've got to keep track the difference between being able to predict something and being able to do something about it. All right, and this is another way of looking at it. Prediction is not a policy. It doesn't tell you what to do. And now there are machine learning systems that try to learn policies. Okay, they're called reinforcement learning systems. And reinforcement learning systems are kind of like what you would expect. There's some environment, and agents make observations about the environment, and they take actions in the environment, and every so often there's a reward or a punishment. And the first example I showed you about supervised learning, that takes enormous amounts of data. This takes ginormous amounts of data to do this. But there's some really interesting examples that show the potential for this. And my favorite one is about this. This is a reinforcement learning system for treating sepsis. Now, sepsis, if you're in the ICU, sepsis is your last step before you die, okay? Most patients, before they're going to expire in the ICU, will go through this sort of general organ failure. Everything's kind of fallen apart at once. And there isn't very much docs can do about it. They can basically give you things to affect your blood pressure, and they can give you fluids, and that's pretty much it. But it's interesting, there was enough data, more than 2 million examples of this from 10 years worth of treatment in the ICU, that allowed a reinforcement learner to try and figure out what its optimal policy would be about treating people in the ICU. And it turns out the AI policy is slightly different than the traditional clinician policy. It tends to give intravenous fluid doses later and smaller, and vasopressor a little earlier and a little more. And it turns out that this has a better outcome, and demonstrably over millions of cases. And this result, which was published early last year, is actually affecting the way clinicians do their work in the ICU. It's really changed the way policy works. And so there are things machine learning can do in these more complicated situations where we can actually try and figure out what the causal features are and what manipulations in the environment will make us better off. But this is really hard to do, and there are fewer examples of these. The supervised learning thing is now everywhere, which is why you're seeing all this hype about AI and machine learning everywhere. That's really the points I wanted to make. I think we have to be careful to be cautious about this new technology. We want no algorithmic snake oil. Remember, snake oil was part of medicine 100 years ago. And we got serious about getting rid of the snake oil in medicine. We now require the FDA to certify that new kinds of medicines are safe and effective. And we need to do the same thing with artificial intelligence. These algorithms aren't magic. A lot of the claims that people make for them are overblown. So it's really important that we treat them the same way we treat all other aspects of medicine and make sure they're safe and effective. And an interesting thing has happened in the last few years. These are FDA approvals of AI-ish machine learning kinds of things to detect these various medically important activities. And there's a whole bunch of companies that are busy out there trying to make new AI technology, new machine learning technology practical in the clinic and prove that it works. But this is still, it's a little over a dozen. And this is all there are so far. But there's more coming. You can see that this is a regular march. Almost all of these were last year. And so this is an exciting time for AI in medicine. Things are really going to change, and they're going to change for the better, but in an incremental way that's makes sense in the general development of technology in the world. Thank you very much.
Thank you, Dr. Hunter. So our next guest is Foster Goss.
Great. Okay. I'm Foster Goss. I'm an emergency physician and clinical informaticist in the Department of Emergency Medicine here at the University of Colorado School of Medicine. And I have a passion for healthcare technology and how we harness that to actually improve the care that I'm delivering to patients every day. The technology landscape has changed quite a bit from 20 years ago. Currently, EHRs are in approximately 85 to 90% of all health systems or clinics. And this has fundamentally changed, actually, the way we interact with patients. I mean, most of us actually went into medicine to take care of patients and actually interact with them on a day-to-day basis, whereas now we're spending upwards of 50% of the time actually in front of our computer. And 38.5% of the time, we are actually spending doing documentation. So electronic health records are the substrate of how we deliver healthcare today. However, and they offer a lot of value. I mean, we can enter orders, we can track patients' care coordination, we can record tons of data incredibly quickly. However, they are not, unfortunately, easy to use. And the American Medical Association has actually called on electronic health records vendors of these solutions to actually make them more easy to use. And as such, because they're not easy to use, it's changed the way that we interact with our patients. We're no longer spending time sitting at the bedside talking with our patients as much as we are spending in front of a workstation. As a result, a lot of clinicians have taken on scribes or medical assistants to actually help them document and actually click buttons in the electronic health record for them and document that encounter so they can actually focus on the patient. And so the technology actually is a problem in this case because it's not allowing us to actually sit down and actually spend time with the patient. We now are using speech recognition technology as a workaround to be able to enter information easily and quickly into the electronic health record, and this has taken off exponentially. There are many, actually over half of all US licensed physicians now use some type of speech recognition technology to assist them in entering information into the electronic health record. So this is the landscape that we work in, and it's challenging. And I, as a practicing physician, want to talk about sort of 3 cases where we're actually leveraging AI to help improve this burden that electronic health records have put on us. So the first case is a 75-year-old male who came into the emergency department with a swollen wrist. This patient was seen by the emergency physician who quickly and astutely diagnosed that the patient had a swollen wrist. It was red erythematous. The patient was ill-appearing, febrile, and diagnosed a septic joint. The doctor went back to the electronic health record, ordered an antibiotic vancomycin, and the nurse received that order, got the medication up from the pharmacy, hung it up on the patient's IV pole, and started administering the medication. about a couple minutes into that, the medication being administered, the patient started to develop a rash, started to get short of breath. The doctor was called to the bedside, evaluated the patient, quickly diagnosed that the patient was having an allergic reaction. Administered epinephrine. Unfortunately, the patient continued to have increasing shortness of breath and required another dose of epinephrine and eventually an epinephrine drip. The patient went into respiratory failure, eventually ended up having to be intubated and admitted to the intensive care unit. The ICU team came down to see the patient, and one of the diligent residents was going through the patient's chart, reviewing their past medical history. Sure enough, in a discharge summary from several months ago was a narrative about this patient's allergy to vancomycin. However, this narrative was in free text. It was unstructured data. So this was essentially invisible to the treating provider. It was invisible to the electronic health record. So there was no decision support that was actually happening to alert that provider that there was an allergy to this medication. So this is one of the challenges, is that the way that we express a lot of what we're thinking is in the narrative. And as I became interested in this, we went and actually looked back actually found numerous cases where there had been allergies and allergy information reactions, for example, that had been documented in the electronic health record and had been missed. And so we sought, colleagues and myself, to actually develop an artificial intelligence tool to be able to identify these allergies from the electronic health record, to be able to read through these clinical notes. And we used a natural language processing tool that could go through and actually read notes. It could also read information, for example, that was in the allergy section. So if there was information that the clinician entered as free text in the allergy section, which often happens because there's not a structured sort of drop-down allergen to select or a drop-down reaction to select, then that information gets entered as free text, and hence the computer actually can't understand that or read it, or then alert the clinician that there could be an allergy. And as Judy Faulkner of Epic said, it's amazing that one health system may have 8 documented reactions to an allergen, whereas another health system may have 120. There's no standardization of that. And in fact, one reaction could be as simple as just some stomach upset, where the other one could be the patient almost dies. So this effort has really been to develop, in my research, to be able to develop this knowledge base of allergens and reactions, such that there's never a case when the clinician goes into the electronic health record that they cannot select the appropriate allergen or the reaction. And in that way, we can be able to detect this information. And even if it is free text, we have a tool, a natural language processing tool, that can actually read through these notes and can suggest, we see this allergy that was entered in this clinical note. Would you like to add this to the patient's allergy list? Or we see that this is actually not an allergy, and that this should be marked as an intolerance, not a true allergy, and it's actually okay for this patient to get this medication. So we're really excited. In the next 2 years, we're going to be implementing this into the world's largest electronic health record, Epic, and to provide not only our natural language processing system, but also our clinical reasoning system as well, to help make patients safer so that these events don't happen. The second case I'd like to talk about is in the domain of speech recognition. So speech recognition, as Larry was speaking about, is taking off. There's Alexas, there's Google Voice, there's Siri. In medicine, there are multiple vendors and products that are used currently. So I want to share a case of a patient that came into an emergency department where I was working. And this was a young patient, 25-year-old female, came into the emergency department with an abscess on her arm. The first physician evaluated her, astutely diagnosed that it was an abscess, performed an incision and drainage, and discharged her home. He dictated his note, and he said, that the patient had missed her period, and as well as what the treatment was. So the patient went home, but unfortunately was not doing well, came back the following day, had a worsening cellulitis developing on her arm. The second physician saw and evaluated that patient and looked back at the previous note that the physician had written, did not see any mention about perhaps missing her menstrual period, and prescribed an antibiotic that was actually contraindicated or toxic during pregnancy. And looking back, this was a fairly simple mistake. I mean, this was a computer program that was basically processed that physician's recording, but made the mistake of putting in the punctuation mark instead of the menstrual period. So these types of errors are concerning, and it's something that we are seeing with this explosion of speech recognition technology. We are starting to see that there are a lot of these errors, and my colleagues and I sought to actually quantify the amount of errors that are entered through speech recognition technology into the electronic health record. And in the emergency department, we found that upwards of 15% of notes contained errors. And these were errors that we believed were clinically significant or ones that would change how we would take care of that patient. We also looked at dictation that happens in the traditional sense of when I speak into a recorder, or if I were to speak into a phone and that information were to go to a human transcriptionist, and what would the error rate be if the human transcriptionist was actually reviewing the clinician's dictation. And we found that only 0.3% of notes contained errors with that method. As the human transcriptionist could tell, they're very good at picking up these errors, and they're all too aware of how many errors are actually entered by this technology into clinical notes. And approximately 9% of those were clinically significant or ones that would actually change the way we would take care of that patient. And some of these errors are concerning. For example, we found where the instances where the clinician would list perhaps 5 or 6 different allergies. However, the speech recognition engine would only pick up 1 or 2. In one case, it would substitute a medication name, verapamil for rapamune. We've seen errors in dosages that were given. And probably most concerning, we saw one where the clinician said the biopsy was inadequate to exclude neoplasia. The speech recognition engine interpret that as adequate to exclude neoplasia. So these errors happen, and right now, the only thing that's preventing these errors from getting into the permanent medical record is careful proofreading of the clinical notes by the physicians. So we sought to develop a artificial intelligence tool that leveraged natural language processing and language models and machine learning to be able to detect these errors before they actually get entered into the electronic health record. And we've been working over the last several years to develop the knowledge base to be able to do this, the technology to be able to do this, and in the next couple of years actually as well, are going to be implementing this through an application programming interface in Epic that actually takes the clinician's note, sends it out to our natural language processing tool, our AI tool, and then sends it back into the electronic health record for the clinician to review. And our hope is that this will actually make the quality and safety of patient care better. The last case I'd like to talk about is one that's very personal to me. I'm an emergency physician. I see upwards of 30 patients a day. If I'm working in the front of the department, in the intake area, I may see as many as 100 patients in one day. It's challenging for me to be able to review all of the information in that patient's chart. Any patient could have, depending on the complexity of their illness, could have between 5 and maybe 200 notes in their electronic health record. and thousands of data elements for me to review. And I have a limited amount of time in the emergency department to be able to thoughtfully and carefully review all these notes. And right now, I have to actually review these manually. I have to cull through them individually. So typically, I try to find the most recent discharge summary to see if there's information about that patient's, say, recent admission, and in essence, trying to cherry pick what are the different things that would be contextually relevant to that patient's presenting complaint. However, that's hard to do. And if I were to actually fully review that patient's chart, it would probably take me 3 to 4 hours, which is almost half of my emergency department shift. So it's not possible. And in the human brain, it's not possible for me also to go through thousands of pieces of data in seconds. So we sought to develop actually a tool that would work much like Google. So for example, in Google, when you do a web search and you query the web, you typically don't have to go beyond the first page of hits, and you can find the information that you're looking for. All that information is actually ranked in some sort of relevance to your query. So imagine going into an electronic health record where none of that information is sorted for you. It's placed in different buckets or containers, so you can look in different sections of it, but none of it is actually organized in any way that it's relevant to what the patient's presenting problem is. So we sought to develop an information retrieval tool that leveraged natural language processing and also unsupervised machine learning. And this could take the patient's complaint, if it was chest pain or if it was back pain, and sort through all of the information that exists in that patient's medical record in seconds. And we started looking initially just seeing if we could identify relevant problems, and then we moved on to seeing if we could identify relevant medications. And we used an unsupervised machine learning method because we didn't want to have the clinicians have to train the system. We wanted to develop a universal tool that could essentially go in and identify what is relevant based on the association of information with each other and to the patient's presenting complaint. And we were astonished. We were able to actually identify 80% of relevant medications and problems for the patient's presenting complaint in seconds, versus a clinician having to go through and actually manually cull through all of that information. So we're going to be extending this further to start to now look at laboratory data, to look at procedures, to look at imaging data, and using that same method to be able to bring all that information so the clinician has that information to make the right decision at the right time for that patient. So these are clinical examples of how we are leveraging artificial intelligence today to help improve the care that we're delivering to patients. And in my view of artificial intelligence as a frontline physician, I see these tools as being incredibly helpful in reducing the burden of me as a clinician having to document encounters, finding information for me, providing all that information to me so I can make the most informed decision for that patient, and allowing me actually to go back to the bedside, to be with that patient and know that I'm providing safe and effective care. Because right now, medical errors are the leading cause of death behind heart disease and cancer. So I think artificial intelligence has a tremendous potential to actually improve the safety of the care that we deliver for patients. Thank you.
Thank you, Dr. Goss. Now I'd like to bring up Dr. Clay Smith.
Thanks. So I'm going to take you on a bit of a deeper dive on a single disease. I'm a blood cancer doctor, and so I want to talk about a blood cancer that's been really very tough for a number of decades, but we're starting to see some real progress that I think AI and informatics are really going to impact in a very important way. So acute myeloid leukemia is a disease where white blood cells grow way too rapidly. Your body has about 3 trillion white blood cells. 3 trillion blood cells. You make millions every hour. That has to be very, very tightly regulated. And if you make way too many blood cells, you get sick really quick. You get infections, bleeding. If you don't do anything about this, people only live for weeks to months. Affects about 20,000 people a year in the U.S. If any of you remember the movie Love Story, that was, I think that was the name of it, many years ago. That was an example of this. This is a survival curve. You saw an example of this earlier. This basically tells us over time how many people are alive with acute leukemia, and you can see this is dreadful. What this is telling you with the blue line is that in the 1970s, after a couple years, only a few percentage of people were still alive. Since 1970, up to that gray curve, almost no progress, no changes in treatment. The last big treatment advance up until a couple years ago was in 1973. So my entire career as a doctor and beyond, the treatment for this disease has not changed. Terribly toxic to people. 1 in 10 people don't even survive the treatment. Many go to the ICU, and it costs a ton of money for these terrible outcomes. So about a decade ago, a concept came along called precision medicine in cancer, which said, instead of giving everybody the same chemo and hoping that things work out, which as you can see, did not work out, let's start being smarter and thinking, well, every single person is different, every cancer is different, how people tolerate chemotherapy is different, and let's try to start using our understanding of biology and burgeoning understanding of informatics to try to find the most effective and the least toxic therapy that we could apply to individual patients. Makes total sense. Kind of shocking it took 40 years to get to that point. This ended up being a convergence of stuff we were learning in the clinic, stuff we were learning in the research laboratory, and working with really smart doctors like the ones you've already seen around informatics, and trying to bring all that together to make better decisions. So the typical way this is done is that the cancer, in this case leukemia, which we can pull out of the blood or the bone marrow, gets sent to a lab, it gets ground up, and they do a process called next generation sequencing. And that's sort of like sending if any of you have done 23andMe, it's a very similar process, but they're looking at the cancer instead of the person. And then we will get a report back saying, aha, these are all the genetic mutations in this cancer, and here's some drugs that may work against those specific mutations. And this is a list of the number of companies and academic activities that are trying to really follow this model. And that model makes a lot of sense, I think, on the surface. Find out what are the genetic changes that lead to leukemia and develop a drug that will target those and hopefully kill the leukemia. Well, after about 10 years of this is the kind of improvements in survival we saw. So the red curve is standard chemotherapy alone, and the blue curve is chemotherapy plus a drug that was identified by genetic testing as a drug that should be very active against the leukemia. That difference was called a game changer, front page of a lot of newspapers, led to FDA approval, lots of money for the company that makes that drug. But I don't know about you, but I don't think that's a game changer. That looks like a tiny incremental improvement. We must do better than that. So here and elsewhere, we've been thinking a lot about why it makes a lot of sense. If you know the genetic changes and you have a drug against that, it should work. Why doesn't that work? And I think one of the many things that the reason we think it doesn't work is that cancer cells are very complicated. On the upper part is the DNA. That's sort of the heart of the cancer cell. But beyond that, there are layers and layers of increasingly complicated biology that are really not looked at or captured when you just sequence DNA. In other words, you just get a very tiny view of all of the very complicated biology that's going on in the cell. And we call these layers of biology omics. There's a whole bunch of names, epigenome, transcriptome, et cetera. And the good news is that over the last decade, we have many, many fancy machines, technologies that can now look at all of that complex biology and generate lots of data. The bad news is it generates lots and lots of data. So each individual sample we look at, if you look at every layer of that biology, you end up with what are called terabytes of data. That's more than the hard drives on any computer that I own for a single person. And we have to do this for hundreds, if not thousands of people. So we're faced with, 20 years ago, we knew nothing about this disease. We had no drugs. Now we're generating terabytes and terabytes of data on each person. And so the pendulum has swung 180 degrees, and we have to have tools to be able to figure out what to do with all that information so that in a clinic, like you heard from Foster, we can make a decision in real time that can help people. And that's where machine learning that you heard about earlier, we're hoping that the artificial intelligence, particularly some versions of machine learning, can come along, sort through all of this complex data, and then very quickly give a doctor like me guidance on how to make the best decision for the best drug for that patient, hopefully work a lot better than what I showed you a minute ago with the 23andMe version of this. The other thing is all that data gives you is a wealth of new information about cancer so that you can now go back to the lab and start to discover new drugs and get new insights into why did this cell turn into a cancer cell and how is it different. So to make all this work, you have to have an environment where you can bring a lot of clinical data together with all that terabytes of omic data. That's not a trivial technical issue. Luckily on this campus, Element and others have had the foresight to build such an environment. It's called Compass, where we can marry this data together and then layer on top of it tools that allow people to analyze this data, visualize the data, and then hopefully embed machine learning to be able to sort through that and give us quick and accurate answers. And all that has to be done in a way that is what's called HIPAA compliant. It has to be aligned with a lot of government regulations. It has to be secure so nobody can hack into it. It has to be accessible so someone like me can sit in my clinic and very quickly draw this up and use it to help guide decision making. And I think we have an early example of all of those things converging together. One of the things we've learned in the course of this project is that this really is a team sport. This is actually literally the group of people that are on our team working on this. I'm the little guy up there that says AML Clinical. We have experts from the research laboratory. We have experts in informatics, experts in statistics. One of the things I've learned is that computer scientists are just as specialized as physicians. I thought all computer scientists, they could figure out how to fix my computer and write code in 14 different languages and do all kinds of stuff. They're highly specialized as well. So we had to bring all of these people together, and we had to figure out a way for all of them to talk to each other, be respectful. You can imagine a bunch of smart people in a room, the ego issues that may happen. Got to have people that are interested in each other's fields. I'm not an AI expert, but I love being taught by our AI experts what's going on. It's really fascinating. And I think the key for all this moving forward is this is not an electronic medical record problem. It's not a statistics problem. It's not a doctor problem. It's a problem that's only going to be addressed effectively by a big team of people that have all of these disciplines, but that can work well together without heading off in different directions. So with that team together, we've just started to see some really exciting examples, and this has happened at a time when finally the treatments themselves for leukemia are changing. We now have a really neat new therapy for leukemia that's pills and shots. People in the hospital for a week instead of a month. It's very, very easy to take. We've given it to people who are 90, very mild side effects. And we probably are able to cure now about 30-40% of people with that. But with the precision medicine and machine learning to guide us, we think we're now identifying people that don't respond to this at all. So we can start directing them to a totally different treatment. We can start identifying people that respond for weeks or months, but the disease comes back. And then there's been some people that we really don't understand that go into remission for a couple of years, and then the leukemia comes back. But all of that, analyzing all of that information that I showed you, the terabytes of information, and coupling that to what we know in the clinic, we believe is going to help us find when somebody walks in the door, are you likely to be cured? And if you're not, let's direct you to another therapy that's going to be more effective and hopefully not toxic as well. So this is a little bit more of a deep dive on one disease, but we think the same paradigm in precision medicine we can apply to other blood cancers, and many other diseases like autoimmune diseases or infection. The principles are the same. Once we work out the details about how to manage all of this information, and I think very importantly, how to bring together this big multidisciplinary team to work well together and be able to accomplish a lot more as a group than any of us could do as individuals.
Thank you very much. So I guess I'll start the question off because I read a New York Times article about this subject, and it raised some alarms for me. And it's something that Dr. Hunter was talking about, and that is so many of us have different ethnic backgrounds, and artificial intelligence uses examples as a basis for predicting future models. How can we guarantee that all of our differences are reflected in the predictive modeling so we'll be treated the right way as Dr. Goss was talking about?
Everybody's looking at me. All right, well, so it's really important. So when I talked about the training, giving lots of examples to those AI systems in order to train the machine learning algorithms, if the examples have biases in them, then the algorithms will reflect that. And so it's really easy to reintroduce biases that are already there in the AI system. And perhaps the best examples of that aren't in medicine, but they're in things like loans or the use of machine learning in courts. So if banks already redline, they are biased in the way they give loans, and you train a machine learning system on the history of do you give a loan to this person or not, it'll reflect exactly the same biases that the loan officers did. That's where the training data came from. So there's increasing awareness of that. I think the New York Times article talked about facial recognition. Now, facial recognition works much better on Europeans and better on males and worse on women and worse on people who don't have white skin tones. And it was easy to figure that out. There's a bias project at MIT run by a woman named Joy Bulalimi, who's wonderful at picking this stuff out, and sort of embarrassed the people who are selling all this facial recognition technology. And so we have to be aware of those things. Some of them are easy to fix, so doing training with a more diverse collection of faces for facial recognition helps. But I actually want to pick up on something that Dr. Smith was talking about, which is the right way to be aware of these issues is to have diverse teams building the projects, doing the tool building. So people whose experiences reflect the broader experiences in the world, right? What is it like to be a patient? What is it like to make sure that the training is unbiased is probably best done by having the teams of people working on these things be as diverse as the population.
Thank you. I had another question. I can ask questions all day, but this is for you guys. But another question I have is, given that there are mistakes that we're recognizing, do our policymakers have a responsibility to ensure that decisions are as mistake-free as possible before we allow this to get into the everyday workload?
That's you. You're the mistake guy.
So I definitely think that there is artificial intelligence has the capacity to bring information to the decision-making process. However, ultimately, I don't think it should actually make the decision for the doctor. I think it only provides information for them to, these tools can't see that patient in the way that we are looking at that patient. They can't smell that patient. They can't understand the unique nuances around much of healthcare these days, we're finding out key determinants for outcomes, maybe things that are more personal to that patient. Their financial status, do they have housing, do they have enough medications, these social determinants of health. I think these are things that, again, come into the decision-making process for that clinician to help aid that decision-making process and to help them from preventing a mistake from occurring. But I also see that a lot of technology, if you don't have the right training data, could actually introduce errors as well. And so there is, I think, an importance that we're using the right data to make the right inferences, to provide the right information to that clinician. But ultimately, they'll have the choice of what they want to do with that information.
Yeah, can I add to that a little bit? I really like the way you put that. And with respect to policymakers, so I pointed out how important FDA regulation was in making sure that we treat these technologies the way we treat any other technology we'd like to introduce into medicine and make sure that it's safe and effective. But an important thing about these machine learning systems is even though they look like they're working like people, like it's picking out dogs in the pictures or reading a retinal fundograph to predict whether it's got retinopathy or not, they work very differently than people. And so there's a complementarity. The machines can sometimes pick out things that people can't and help us avoid a mistake. And people can sometimes pick out things that the machines don't see and avoid a mistake. So we're actually stronger working together. We can make things safer and better by using both the capabilities of the technology and the capabilities of the people because they're complementary. They don't replace each other.
So given the potential dramatic nature and the way information will be processed and handled as these technologies emerge here, what would each of you prescribe to the curriculum committee, both in the short term and the longer term, on how we should change the training for physicians and other health professionals?
That's a great question. So you guys, I'm actually curious about your opinions about that. So you came up through that training system, and you presumably got nothing about computers or the kinds of errors they make or how to use them or how they work. Now that you know a lot about this, what do you wish you knew when you were being trained?
Well, I'm so old that we didn't even have computers. We had Pong was the big advance. So you've raised a great question. So I'll just give you my opinion. I don't think any one person can know all of that stuff in that circle of experts that I told you. But I do think it's key that those people can all talk to each other. So I'll give you an example. I have no background in this. I have background in laboratory research and clinical research, but we live in an age where there's edX and Coursera and other courses online. I'm going to try to do a master's in clinical science, which will be really interesting, doing a master's next to a bunch of really smart 20-year-olds. I hope I can crush them on the test. So that's a very medical student sort of approach things. So I think there's definitely a need to expand beyond the core curriculum of medicine and biology to include some of these topics. I think it's so broad, it's hard to envision how you would do that within I didn't get a real job until I was about 35. It took so much training with just those two things. So it's a bit hard to see how you'll fit all that in. I also think there's an enormous amount of training that could be done around teamwork, how to be respectful of people in different cultures, how to communicate across these cultural divides, in addition to just learning the nuts and bolts of a little bit of Python, so I could maybe throw some buzzwords around with one of my colleagues here. So I think it's going to be a balance of expand that curriculum to include some of these areas to give some people, and if there are individuals like Dr. Goss that really want to dive deep, an opportunity to do that. But I also think a lot of work in teamwork.
Yeah,
So
go ahead.
I would just say that I think that there's, for medical education, I think it's critical. I think physicians need to know how to work with the technology. They need to know how to use electronic health records to help them find information. We see clinicians who struggle. I mean, even some physicians have decided to retire because of the burdens that electronic health records have put on them. So it's really imperative. This is the substrate of what this underpins all of our health systems and clinics today, that clinicians receive training in their curriculum about how to actually use electronic records and use them intelligently, and how to leverage them to actually improve the care that they're delivering. And with a lot of these technologies that come out, you can't, so much of the effectiveness of this technology is actually in the education of that end user of how to use that technology. If you just give a technology to a physician, they are unlikely to use it unless they really know how to actually get out of that technology what it's supposed to do. So I would say that that's something that in the medical curriculum, I could see there being a lot of value in educating upcoming physicians on how to use technology, and also in a way that doesn't interface or impact or surplace that interaction with the patient. That's really, really important of when to use technology and when not to use technology. For example, when I go in and I see a patient, I leave everything at the bedside. I do not carry any technology in with me. I am focused solely on the patient's encounter, because I know that the information that I'm getting out of that encounter is so rich. The probabilities that I'm getting from the question that I'm asked, the questions I'm asking, are actually far more powerful with information from the electronic health record than they are with just the information from the electronic health record. So it's really important to educate them also, for example, speech recognition technology, how to use that technology in a way that they can convey complex ideas in a seamless way, so another clinician can actually understand what they were thinking. So it's important, I think, in medical education.
Yeah, and I guess I would add to that there's no one right answer to this. So the last couple of years, for the first time, there's now a clinical specialty where you can board certify in medical informatics. So for the people who really want to do the deep dive into this, there's an opportunity to really learn sort of the whole waterfront. But every hour in medical education is valuable, okay? We have to, in order to put teaching to everybody about computers, we have to take something else out. And so trying to figure out what the minimum amount everybody ought to know is a tough thing to do. And another challenge is the fact that it all changes so fast. So, what I would have taught you if I had an hour to teach every medical student something about computers, what I would have taught 10 years ago is different than I would teach today. And I guarantee that what I would want to teach 10 years from now will be different than what I want to teach today. So you have to figure out sort of the right way to do that. Medical curricula don't change that fast. So we need some way to figure out what's that baseline. And I think a lot of it is related to what Dr. Goss was talking about, which is the safety issue. So there are fundamental things that people have to understand about how these technologies work in order to use them safely. And I think that's the sort of bottom line that every clinician ought to be trained in. What kinds of errors occur? What should I be on the lookout for? And then the deeper bits about how does this stuff work and what are the underlying fundamental theories and all that kind of stuff, that's for the people who want to go down that path, not for everyone. But I do think there's a baseline that ought to end up in the curriculum, and we don't have that yet.
My question is, I'm sure you've all heard of IBM's Watson program. I'm kind of curious if Anschutz actually works with the Watson people for some of their different programs they're using. And normally, I think they just are working on cancers right now, but I heard they were expanding it, so kind of curious if you're working with them.
So Watson, I think, I think you've heard from all of us that I think we all envision that the best way for this to work is a hybrid of smart people and computer assistants. I personally think Watson was hyped as something beyond that it was really just gonna be telling you everything you needed to know. And I think it's been disappointing in oncology. And if you read the newspapers, there's been quite a bit of turnover in the leadership of Watson, of the medical applications of Watson. And I think this is a little bit symptomatic. Again, this is just my impression as a doctor of a larger issue, which is that many people in Silicon Valley, which is where my kids actually live and work, so I hear this day to day, they view a lot of these issues as solvable purely by engineering solutions, by computer-based solutions, without really understanding that this is a very complicated culture. Medicine, at least in my field, is still a lot of art, a lot of mystery, a lot of magic. And I think we're going to have to do a lot of work in coming years to figure out how do we deconstruct that magic and turn it into something that's more tractable by computers. And during that time, there's going to have to be a lot of human-computer interaction. I don't know that Watson captured that sufficiently in oncology, at least, but I would defer to others. It plays chess very well, I think.
Jeopardy.
Jeopardy.
Yeah, so I actually know the guys who led that original Watson team, and I'm an old guy in AI, so I know this. And I think that the technology they developed was very impressive, particularly for playing Jeopardy. And the spin they put on and the marketing that they used to try and sell this into medicine was a good example of that snake oil I was talking about we have to be very careful about. So the natural language processing technology that enabled it to answer Jeopardy questions at better than human is really fascinating, and there were some important developments when that happened. And then inside the IBM organization, once that had been developed, the business folks took over and said, okay, where's the biggest market we could imagine applying this? Because it's going to be really expensive, and we're going to try and, a company-sized bet on doing this. Who has that kind of money? And their take on why it should be applied to medical care had nothing to do with the fit of the technology to solving actual problems in medicine. It had to do with the size of the market. And so that was a poor way to make that decision. And a bunch of people, MD Anderson in particular, really got snookered by this. They put enormous resources into trying to hook Watson into their cancer center, and ultimately couldn't really make it do anything terribly useful. The best examples they had were on tumor boards where the Watson would consult and try and make some contribution. And the few places they found things that the oncologist didn't already know were things that had been published very recently, that the oncologist just hadn't had a chance to read that journal article yet. And if they had, they would have been able to do better with it than the program had, but the program was kept up to date overnight, so it knew yesterday's journal publications. And it's a good example of why we need the FDA to carefully regulate this stuff. It really didn't help that much. In some ways, it was really impressive how much oncologists know and how good they are at staying up to date with things, and how little computer program that could answer short answer questions, play Jeopardy, wasn't of tremendous use there. And so we have to make sure the technology is impressive, but the application was just misguided. It didn't fit. And so we have to figure out, when we have these cool new technologies, where can they actually help in medicine? Where are the places we know we could do better, and is that a technology that could help us there? And I think the answer with Watson turned out to be no. There isn't a place where we can use that in medicine.
Then I think there's also a gap as well as to that information, that knowledge that is generated in Watson. Then how do you translate that into a clinical workflow and actually how do you make that actionable, for example, for a clinician, and how do you actually tie that to their orders or to their clinical reasoning system in the electronic health record, which is a huge gap because you're going through multiple terabytes, if you will, of data or petabytes, and it's very challenging then to create an actual direct action from all that information for a particular patient.
Yeah, I want to speak up for science for a second. So I talked about the FDA and the importance of federal regulators, but the traditional way we evaluate technology and science is the peer-reviewed journal publication. And there has still not been a peer-reviewed journal publication of Watson in medicine. So I think that we could tell that we should be suspicious already because they're not doing the regular science thing of exposing their methods, showing us the data, let us look at the results. The peer review method is a good start. And the fact that there are no Watson journal articles in medicine is a real powerful indicator that it didn't work.
I think Dr. Winia had a question, and another gentleman.
First off, thank you. You guys are fascinating. I used to think I was smart, then I started coming to Anschutz for these things. I'm really fascinated, and you brought up learning and journals and everything. I am fascinated about how doctors spend their week, their day, because they do so many things. But for the three of you, since you're all in three different areas, what does your work week look like as it relates to these three things? Your job, learning more about your job, and then doing stuff like this and collaborating with others to advance medicines. So is it 75, 25, 5, meaning 105%? Or what, how does that work for each of you? Because I'm just fascinated.
Go first. Not well. It's the single biggest challenge, I think, for many of us is time management. So I have an administrative role where I run a blood cancer program that oversees several tens of thousands of visits a year, hopefully with no mistakes. Both inpatient and outpatient. We do bone marrow transplants, cellular immunotherapy. So I have to, unfortunately, spend a fair amount of time with like budgets and HR and stuff like that. That's not fun. Then I'll go see patients, which is what I still love the best. Then I have a research lab, which I have to meet with people and make sure they're doing research. Then I spend probably a quarter of my time working with that multidisciplinary team I showed you, trying to figure out how we can advance medicine through that intersection of research in the lab, clinical, and informatics. And then because the weakest of those areas for me is informatics, I'll go home at night and in between taking care of a brand new puppy, which is a handful if anybody has done that, I try to take Coursera and edX courses so I can get at least enough of a little veneer of knowledge so I can more effectively communicate with people in those teams. Luckily for me, my kids are now are grown, so that's opened up a little bit of time. But it's a full week. I would tell you it's I get into medicine almost by accident, but it is a really rich and wonderful life. There are plenty of lows, plenty of frustrations, lots of bureaucracy. These EMRs are like 1980s technology that have been forced on us without really much input from the people that use them. But at the end of the day, what we're doing is really important, helping people live better lives and changing the world for better. And it's really fun to be busy doing stuff that's really important and rewarding like that.
Yeah, I think my experience is similar. So I wear several different hats, and I think my favorite thing to do is take care of patients in the emergency department. But I also love technology, and so I've applied for numerous grants. So my grant work and funding buys down clinical time, so I can split my time between doing research and informatics. I was one of those people who went and did an informatics fellowship after my residency in Boston and spent quite a bit of time very thick into doing informatics research. But I also have other roles as well. So as a informatician, I'm also a chief medical information officer for a company. I basically juggle between my clinical practice, my CMIO role, and then also my research and grants.
So I'm the only one here who doesn't touch patients. And apparently I'm really missing out. But it gives me more time. And so my role is largely split between research and teaching. And I love my job. And one of the things that I say that I love most about it, it is my job to learn new stuff every day. So I spend a significant chunk of my day trying to keep up with the fire hose of new methods, new results, new applications, all that sort of stuff. I run a graduate training program, and I have, at the moment, 4 graduate students in my lab and a postdoc. And a lot of the learning I do is from them. Okay, so they're spending all the time trying to learn new stuff and try new things. And so my interactions with them are, I think, my most satisfying part of the day. Because they come up with crazy ideas. My student who most recently graduated had a machine learning application that I won't go into the details of, but when he came to me and suggested, hey, we can design this machine learning system this way, I said, oh God, there is no way that is ever going to work. That makes no sense. But go ahead, you try it. Let's see what happens. Works better than anything that's ever happened in this particular field, okay? It really was spectacular success. And you know, my students keep me humble. They definitely discover and figure out things that my intuitions, my decades in this field suggest probably weren't the best way to go. But I love when they surprise me with stuff like that. I also spend a fair amount of my time, I wouldn't call it administrative stuff, but writing grants, trying to bring in the money that allows this work to happen. One of the things that's challenging about our field, mine at least, is that getting money to do this work, to pay those students, to buy that equipment, to go visit people who are doing this stuff, is really hard. There isn't enough research money to support this stuff. And so a lot of my time is spent trying to raise that money. And then a significant chunk of my time is spent meeting new collaborators, working in these big teams. I think Clay and I will probably get together after this and figure out if there's something we can do together. But going around campus and talking to people about their issues and their concerns, and it's a big, rich place here. There are thousands of researchers on this campus, and all of them are doing interesting stuff. So even just here, there's a lot of people to sort of synergize with and to learn from, and that's a fun part of my day too. We all stay pretty busy.
So when do you sleep?
Well, not this morning, that's for sure. The surgeon's hour thing is a little tough on me. No, one of the things about living in Colorado is it's possible to really have a work-life balance here. My kids are not quite as old. I have a high schooler and a college student up at CSU, and so I need to make sure I have time for them. And a little time to go, breathe, meditate, ski, whatever it takes to make sure that I'm fresh and able to do this stuff.
Back in my day, they taught us how not to sleep.
Make more mistakes that way.
You do. It's different now.
Does anyone else have any other questions? Dr. Winnie, why don't you share your question?
Well, thank you. First of all, this is a wonderful hour and a half of learning this morning for me. I'm wondering about implementation and about sort of the cognitive psychology of all of this. We, in the brain of a human being, when you see something on paper in black and white, when something spits out of a computer, we've got a sort of innate desire to trust that and move forward with it. And I'm wondering what the role of people in implementation science and cognitive psychology are on your team in terms of how to bring this kind of information forward in a way that is nuanced enough that we question it when we should, and directive enough that we pay attention to it when it's telling us to do the right thing, even though our intuition says we should do the way we normally do.
Right. I can take a kick at that. So that is a great question and a great point and a great challenge for all this. So as you heard, there's this fire hose of information that we're all exposed to. Even in the clinic, as you heard, there can be hundreds of pages of records. So getting information into that stands out is really important. Epic, our EMR, fires off these little warnings all the time, and it frankly does it so much. And 99%, there's still warnings about Ebola virus, which I haven't seen anybody with Ebola virus lately, have you? So you get deluged with these kind of things, and eventually people just, they ignore it. It's like getting 200 emails a day. You just start not paying attention to them. There's some other practical issues. The paradigm I showed you of precision medicine, where people do the 23andMe type genetic testing, takes about 4 weeks to get an answer back. Almost everybody gets that testing. It costs about $5,000 a test. You get an answer back about 4 weeks later. It's completely irrelevant by that time, and yet we all sort of keep doing it. So that's another bit of background noise that you have to sort through. The other is, you heard a very practical example from Dr. Goss. We see anywhere from 10 to 30 to some days I'll see 50 people in a day. That gives me 5 minutes, 10 minutes to crunch through all of the thinking part, particularly if I've spent a good amount of time talking and listening, which we should do. So there's some practicalities about how do you fit that into a very busy workload where you're shifting from one person who you're giving great news to 2 minutes later you're having to give terrible news to somebody to the next person, and that happens every day, day after day. So getting this information in a timely fashion, in a way that stands out amongst all of those background and deluge of other information, doing it in a way that's quick and informative and compelling and helps people make decisions rather than distracts them, which frankly most of the EMR data I get is distracting rather than helpful. That's a huge challenge. So for us, what's been key is that this was not a project that was solely led by engineers and computer scientists, but that clinicians, busy clinicians who need to do this in a practical way every day, have a lot of input. I use the analogy a lot of it's hopefully being designed like the iPhone, which my 86-year-old mom can use all the time to call me a lot, versus somebody having to sit down and do something in DOS or something else to actually get something done. We have to make it user-friendly. We have to make it stand out. It has to be driven, in my opinion, by the users rather than the engineers. It has to be a real partnership. But that is a huge, huge challenge. And probably at some point in that team, we should reach out to people like you're describing to turn that into a more organized and disciplined element of. We're not yet ready to implement this, but I think as we get closer, we probably should reach out to people with that expertise as well.
Yeah, I'd like to riff on that a little bit. I think you raised, Matt, a couple of really important points about the psychology of the people using the tools, but I'd also like to pivot a little bit and think about the system that the tools are embedded in, the healthcare system. And part of the reason that EHRs, EMRs, these electronic patient records, don't meet the needs of clinicians and patients so well is clinicians and patients don't buy them. Okay, the people who buy those systems are hospitals for the most part, are administrators whose main worries are really about making sure that they get paid for the work that happens and making sure that when they get sued, they can document that they did the right thing. And so the systems that we have are really good at generating billing information for insurance companies and really good at saying, yes, you counseled this patient about risk of falls or whatever else the latest lawsuit du jour is, and not so good about supporting the work of clinicians or taking care of patients. And because the way the system is set up, because of who pays for those systems, the designers are very responsive to the people who are buying them. And that's not the same as the clinicians or the patients. And so that, you can tell from your iPhone example that it's possible to design really beautiful interfaces that are smooth and frictionless, easy to use, make you buy more, tweet more, whatever, That stuff, it could happen in taking care of patients. It could happen that clinicians are supported really well. But until the incentives of the system are aligned so that that's how the vendors are rewarded, as opposed to rewarding them for helping get the right billing codes to the insurance company faster or defending themselves in the risk management team, then we're not going to see those kind of changes. So it's not just the individual psychology we have to worry about. It's really the healthcare system that these things are embedded in.
And I'd like to, riff a little bit on the psychology part of it, because I think that clinical decision support right now takes the form of interruptive alert, which we all know we get inundated by these alerts. And unfortunately, even with, for example, allergies, even when the reaction to the allergy is anaphylaxis, we know that this is actually overridden almost 90% of the time, that alert to the clinician. So behavioral economics is really important when we're thinking about implementation science. Actually educating also the physicians on why this is a good choice. So that's an area of clinical decision support that I think is very fascinating and it's just now showing to be the psychology part of this. It could be almost effective or even more effective than just an alert. So I think finding those ways to nudge clinicians to do the right thing. We need to give them the right information. That's really important. and that needs to be taken in context, but then we also need to think about sort of behavioral tools that we can use to actually get them to say not prescribe an antibiotic for a viral infection.
And I would say, just to go back to the first question around education, we really have to get physicians and other caregivers a lot more involved in this type of work. EMRs were not only not developed with physician or other care provider input, it was actually actively discouraged. We were told we were complaining too much, slowing things down. And there's probably some truth in that, but physicians and other caregivers must be a lot more vocal in how to make this work within their day-to-day workflow. I fly a little bit, and it reminds me of landing a plane if every alarm system were going off simultaneously while you're trying to focus on getting wheels on the ground. That's sort of the day-to-day experience we have with these EMRs. And in the world of flying, they've spent a lot of work trying to figure out how do you take all this complex information, display only the most important, do it in a way that's not distracting or doesn't get overlooked or simply turned off. And I think there's lessons from other fields like that, but I also think we have to, people like Dr. Goss and I have to spend a lot more time working with these teams to say, look, this must work well within our workflow, and here's why, and do that in a thoughtful and rational fashion rather than what at least I do a lot, which is whine about it.
Well, and I didn't mean to be too negative about the system. We just have to put the levers where the system responds to it. So there's pretty good evidence now that problems with these user interfaces in EMRs are actually an issue for patient safety. And so to the degree that that's broadly understood in those risk management teams and the like, maybe we can get better user interfaces, better EMRs in the name of taking care of our patients safely. But it's not going to be easy. The people who buy them are the ones who influence what they're like.
And I think it's exciting to see what's happening in innovation in the technology outside of the big electronic health vendors. More and more, we know that Apple has an app store, for example, that we can peruse through millions of different apps. I think there's hundreds of thousands of medical apps. But the EMR companies are also creating this ecosystem for new technologies that can be stood up within their system and then implemented into their system. And they make sure that from a safety standpoint, these are not going to harm patients. They make sure that they adhere to the certain requirements, the ONC requirements to be used in an electronic health record. But that's where a lot of what's really exciting in healthcare is seeing these new applications that are being developed that are much closer to what we experience in our civilized life when we're using an iPhone or using Google or something that's incredibly seamless for us to use. And now the integration of those into actually clinical workflow and into the ordering process and the clinical decision support process is really, really exciting and what's driving a lot of the innovation right now in healthcare. The challenge right now, of course, is we don't have an innovation problem in healthcare, we have an adoption problem. So is getting these technologies actually to be adopted because they are really powerful.
Okay, before I ask for any more questions, I did want to tell you that our next speaker series event will be May 7th, and we're going to focus on the innovations in organ transplantation. And we'll have the director of our organ transplant program, Liz Pomfret, in this room. It'll be 7 to 9 a.m., but you can sleep in, Dr. Hunter, on May 7th. So anybody else have any other questions? Yes.
My question has to deal with a little bit about one of the things that you said regarding Watson being useful in terms of maybe keeping up to date on the literature. And I was wondering if that has kind of been developed to more generally in terms of using natural language processing to generate hypotheses for research or kind of direct people towards certain papers over other papers to kind of sift through the thousands of articles that are published each day.
Yeah, so that's more right up my research alley. First, I want to point out that the PubMed, which is the NIH's database of the entire biomedical literature, is recently changed from giving the articles back when you do a search in the date order from most recent to oldest to a relevant search, kind of like Google. And that work was led by a guy named Jiang Liu, who's the director of search at the National Library of Medicine and a former student of mine, who I'm very proud of. So I think there is a recognition broadly in biomedical research in that managing the flow of research publications to the people who need them is really important. And there's a lot of change going on in biomedical publication with preprint repositories and open access rules and things like that. So there's a lot of motion there. The idea that computer programs could sort of absorb all that literature, read more than any human being could, and come up with interesting new hypotheses is one of the things that my lab pursues. I would say that's a goal rather than a reality at the moment. But there are really interesting examples of hypotheses that have been surfaced by natural language processing, machine learning, sort of AI systems. There are a few of them so far that have turned out to be interesting. There's a guy in the UK, Ross King, who does fully automated laboratories. So his programs not only come up with hypotheses based on the literature, but they've got a robotics microfluidics setup so they can do their own experiments and then try to understand the results of those experiments in a closed loop, the computer's doing science sort of system, including the lab work. I think that sort of stuff is really exciting. Hang in there. I think the next, decade or two will really demonstrate that computer programs and robotics and the like will be as important in doing basic science and understanding the world as we've been talking about today and doing the more applied part of using them in medicine. So I think that that's coming, or at least I hope so.
All right, well, thank you all for coming. Are there any more questions? All right, so thank you all for coming, and this has been a really rich conversation. Thank you, Dr. Hunter, Dr. Goss, and Dr. Smith.